Hi, and welcome to the Pro PA podcast. I'm Angie Urbina, your host for the dermatology series. In today's episode, we're tackling Molluscum Contagiosum, a common viral skin infection caused by the poxvirus. While it's typically harmless, its distinctive appearance can cause concern for patients and parents alike. We'll break down what you need to know about molluscum, from pathophysiology to diagnosis and management. Let's get started. Let's begin by discussing what Molluscum contagiosum is and who it affects. Molluscum contagiosum is caused by a DNA poxvirus that exclusively infects humans. The virus spreads through direct skin-to-skin contact, fomites, or auto-inoculation, and it establishes infection in the epidermis. This leads to the characteristic dome-shaped, flesh-colored papules with central umbilication. This infection can affect any age group, but it's most common in children, especially in association with public swimming pools or contact sports like wrestling. A second population is sexually active adults, where lesions often appear in the genital region. And thirdly, immunocompromised patients, who may develop more extensive or persistent lesions. The classic clinical presentation is firm dome-shaped papules with central umbilication. They're typically 2 to 5 millimeters in diameter and can occur anywhere on the body except the palms and soles. A few common areas in children are the trunk, axilla, and flexural areas, and the genital region in adults. Diagnosis is usually straightforward and made clinically based on the characteristic appearance of the lesions. Now, let's talk about the management. Most cases resolve spontaneously within 6 to 12 months in healthy individuals, and therefore no therapy is reasonable. However, treatment may be considered to alleviate discomfort or pruritus, reduce the risk of autoinoculation or transmission, and to address cosmetic concerns or prevent scarring. Some first-line treatment options include cryotherapy, curettage, or cantharidin application. Now, an important note for management of immunosuppressed patients is to treat underlying conditions, like in the case of HIV. This will enhance resolution of the molluscum contagiosum. Prevention strategies for molluscum include avoiding direct contact with the lesions, covering the lesions with a watertight bandage, and practicing good hygiene, including hand washing and avoiding sharing items like towels or razors. A few complications to watch for is number 1, molluscum dermatitis, which is an eczematous reaction around the lesions associated with atopic dermatitis. Secondly, look out for secondary bacterial infections, which may require antibiotics. And thirdly, the possibility of extensive, persistent disease in immunocompromised patients. Let's briefly talk about book med versus street med. In textbooks, molluscum is often described as self-limiting and requiring no treatment. In real-world practice, however, parents or patients frequently request intervention for cosmetic or psychosocial reasons. Therefore, a balanced discussion about treatment versus observation is essential. Here are a few clinical takeaways. Number 1. When lesions become inflamed, this may indicate the BOTE sign. BOTE as in BOTE, which stands for beginning of the end. This is a sign that the body's immune system is starting to clear the infection. Reassure the patients and parents that this is a normal part of the healing process. Number 2, watch for molluscum dermatitis in atopic patients and consider topical steroids. And number 3, in sexually active adults, genital molluscum may warrant STI screening and counseling. All right, let's test ourselves with a couple of clinical questions. Question 1. A 6-year-old child presents with a rash that has been present for 4 months. Physical exam reveals 5 to 8 dome-shaped, flesh-colored papules with central umbilication on the trunk and antecubital fossa. The lesions are asymptomatic and there is no history of atopic dermatitis. What is the best next step? Is it A, observation and reassurance, B, cryotherapy, C, oral antiviral therapy, or D, topical imiquimod? I'll give you a couple of seconds. If you chose A, observation and reassurance, you are correct. Observation and reassurance are perfectly appropriate, as Molluscum contagiosum is usually self-limited in healthy children. Question 2. A 5-year-old girl presents with Molluscum contagiosum that has been present on her trunk and arms for 6 months. The lesions are now tender and edematous, surrounded by erythema. Her mother is concerned the condition is worsening. What is the most appropriate explanation and management? Is it A, this represents a bacterial superinfection and prescribe topical mupirocin? B, this is a normal inflammatory response called the boat sign and provide reassurance? C, this indicates recurrence and initiate cryotherapy? Or D, this represents systemic spread and start oral antiviral therapy? If you chose B, this is a normal inflammatory response called the boat sign provide reassurance, you are correct. The description of inflamed lesions is consistent with the boat sign, which indicates the body's immune response is resolving the infection. Reassurance is appropriate. Awesome job. Thanks for tuning in to this episode of the Pro PA podcast. Molluscum contagiosum may be self-limiting, but knowing how to recognize and manage it is vital for patient education and care. Don't forget to hit the subscribe button and turn on notifications so you never miss an episode. And remember, this is the Pro PA podcast, where future pros in medicine are made. See you in the next episode.